to call the roll.
Ryan.
Here.
Parker. Barnett. Blackwell. Blunt. DeBar. Fillingham. Frazier. Harkins. Hickman. Hill. Hobson. McMahon. Parks. Polk. Tate. Turner Ford. Wiggins. We have a quorum.
Thank you. We have with us today three speakers. The purpose of the meeting is to talk about mental health issues on the county level, dealing with specifically commitments and how that works, but generally what sort of services are available, what are the problems, and so on and so forth. I think I've said this over and over again, but I'll say again, I think many of the problems we have with mental health don't consist of words that we've written down in the statutes here in Jackson, and we don't necessarily need to change the words in the statutes that are here. There are real-world obstacles and real-world problems on the local level. We need to figure out what those are and start trying to find solutions for them. And so that's sort of the focus of the hearing. With that in mind, I've invited, and he's been nice enough to agree to come meet with us, Jamie Altman, a Chancery Clerk from Lamar County. Mr. Altman is going to just tell us what happens when people show up at his Chancery Clerk's office with to talk about individuals with mental problems and how things plays out from there. So, Mr. Altman, thank you. If you'll just come up here and talk to us and proceed however you'd like. Thank you for coming.
Thank you, Mr. Chairman and committee members, for allowing me to come.
I should say you have to speak directly into the microphone. We have a very, very improved system. This is one of the finest sound systems that money can buy. But you have to speak very directly into the microphone in order for anyone to hear you.
Mr. Chairman, thank you and the committee members for asking me to come speak with you all today. As you stated, I'm the Chancery Clerk, Lamar County. Been there for 4 years, recently reelected, thank goodness. Appreciative to our citizens, that's for sure. So I do not exactly know what you all are wanting to hear, okay? I'm going to kind of give you some background as to where, when I came into office, what I saw, okay? And then the steps that we've taken to try to work within the statute and the guidelines to then serve our community and our citizens the best we can in our job. We come into office, new in the description that we dealt with mental commitments and A&D, alcohol and drug, voluntary, involuntary commitments, didn't realize exactly what all that entailed, honestly. I mean, that was something that coming from outside the world of Chancery didn't understand that. Get our feet in here and into the office, get my feet wet, start figuring out the system. And Lamar County was doing a decent job of trying to help our people. I mean, they really were with the services that we had kind of gotten and had tapped into at that time, okay? And so we start looking at the statute, the requirements, start reaching out to our local provider, which in our area, with Lamar County and Forest County, our region is Pine Belt Mental Health. And so reached out to them, started talking with them. That kind of, I'm going to throw another name out with the Departmental Health. I worked with MDOT, by the way. I hope y'all don't grill me like y'all did Brad White earlier, or the finance guys did. But I was with MDOT for 16 years, and I had met Cindy Eubanks that works with Departmental Health. And so I reached out to her. That was another contact. So I started talking with her, developing a relationship. So we just kind of started working within the system to try to figure out how can we help our citizens better, to serve them better. And that has led on an extreme endeavor. to be honest with you. People do not realize that when a person comes in with their loved one, friend, coworker, family member, where they're at when they reach our door at the Chancery Clerk's office, okay? A lot of these people do not have payer sources. They're not, I mean, don't take that we have them from top to bottom. I mean, we have all class structures, everyone. And so, but usually when they come to us, they're in a position that they are at their last straw. They need help, okay? And Chancery Clerks, as I've come to figure out, I came from a surveying and engineering background. They come in many shapes, colors, and sizes. I mean, you have school teachers, you have attorneys, you have CPAs, diverse backgrounds, and we're trying to assist and help our people in our communities, okay, to get better help or help for their loved ones. And so we're kind of by statute mandated to do it, but we're not necessarily prepared to do that or handle that structure, okay? It's not something that's set up cookie cutter for all of us that come in. This is how you do it kind of guide. So started reaching out. Lance Reed from Forest County had became the clerk at the same time that I came in 2020. And he had a lot of knowledge about the mental health commitments. And so working within our framework, we started trying to develop how we take care of our area. Because you can't just take care of one county. If you try to do one county and then all the other areas around you do not have services or provide those services, those quality services to their citizens. The way the statute's written is they can be committed in the county you're found in or live in, reside, okay? And so what's gonna happen is we're gonna start getting people coming in from the outside to try to get our services because they hear that we can help people. So we started trying to look at a little larger view as, the area, a region. And so and this may not be what you guys want to know. I'm just kind of giving you the background of how I got to where we are today. We started working with our area provider, Departmental Health, working within our guidelines, reached out and made really good communication levels with the Sheriff's Department and the police departments around. Learned about MCERT, Mobile Crisis Response Team. Started learning about the CSUs. Took on a lot of different different aspects of our jobs that just someone dropping in may or may not do, or you're overwhelmed. And I'll be honest with you, I'll be the first one to tell you I have a really great staff. Came into a really great staff, and it gave me that opportunity to be able to put time and focus into this endeavor. So with all that to be said, we've determined we needed a crisis stabilization unit in our area. And so we have Westway, which is in in Jones County, and it's a 16-bed facility. So we started on the path of trying to get to a crisis stabilization unit somewhere in Lamar County, and the National Guard Armory came available. We were able to acquire that and have since started. This is a multitude of people in this group, okay? It's legislators, on you guys on the state level have helped. The Department of Health has been a big help. Like I said, Pine Belt Mental Health. This is not a one person can't fix it all. It takes a team to support people in the communities, okay? And, but essentially we've moved our way towards developing and planning a crisis stabilization unit for our area in our region. And with the total goal in mind is to help alleviate some of the pressures off the CSUs that the Departmental Health and the state organizations operate, and have a complementary 16-bed CSU with the way I would phrase it is a one-of-a-kind prototype in Mississippi is what we're looking at. We base it off the 18 that the city of Houston actually is running now on their model. It's got a living room model with a 23-hour hold in it for people. It's got a CIT officer on staff, triage nurse, Medications can be administered, MSERT staff on site, 16-bed unit. So it's an all-inclusive facility. And then the purpose for having MSERT on site is to work with the CSU team on the front end. And because what we find is people who go out of the system, once they've gone through and gotten stabilized, if that's where they are stabilized and put back out in the community, then 3 months down the road, we see them back again. And so we're trying to do a soft handoff. What we want them to work with the people up front as they're coming into the process, so they will be familiar with MSERT and want those services when they leave. Because that's the whole goal. Myself personally, love to not have any mental commitments. That's where I would love for us to be. In the state, I'd love for the state to not have any. But with all that being said, when someone walks into our office, goes through the commitment process, says this person is exhibiting these factors or these symptoms, and we walk them through those. The way the system is currently is you can't, and I don't know how much you guys know about the pre-evaluation system and the patient information sheets. So we have to start taking down documentation for the people coming through the doors and trying to establish whether this person does or does not meet the criteria to move forward with a mental health commitment, alcohol and drug. Is it going to be involuntary or involuntary? So there's a lot of things that Clerk's got to try to navigate before they ever see a healthcare professional. Okay. So when that happens and they go see the healthcare professional, a lot of the times the actual person that you're wanting to commit or your loved one or friend, coworkers trying to get committed, they're not just going to go show up. They're having an episode at that current time. So you can't just go talk to them. I mean, you can't just walk out in the door and say, hey, let me talk to you about you being committed. They're not going to give you those answers. And we don't leave, our office to go find them. So we have to go off of the person that has firsthand knowledge a lot of the time. And so we develop the criteria. We go through it with Pine Belt Mental Health. We tell them what we've got. They do an assessment, just a rough, what we call a screener, to kind of give us a little bit of guidance. And then we proceed through the process, and it goes for a writ, goes to the judge. Judge, he issues the writ. They're picked up, and if they're a mental commitment, the way it works now currently, and it's an evolving system. 2 years ago, they went straight to our jail because it's the only place we had, violent or nonviolent, felony, non-felony. I mean, it just, whatever criteria they fell into, that was the only place we really had to house them. And so we would take them to our jail. And, but it has evolved, the system has evolved so that we now, if someone comes in and gets to that point that they're going to be picked up, a writ has been issued, and they are deemed to need further health care services or mental health services, we reach out to our Departmental Health facilities, our CSUs, Crisis Stabilization Unit in Jones County, they're in our catchment area, and see if they have a bed to hold them. So now, instead of taking them to jail, if we do have a location, we take them there for a landing spot. And I believe several of the counties are doing that now, trying to access and utilize that. But as you all probably have heard, and we live every day, those facilities they struggle with staffing, one, and two, they struggle with having availability because they're usually full. And so they can't really house our people that are awaiting that next level hearing to move forward with their process. So, if they can't or they're violent, they still stay in our jail. That's still our option that we're using. And alcohol and drugs, just to kind of give you a little bit of that, they go through kind of the same process up to the point that a writ is issued. The writ then is served to them if they can be found, and they are not housed in any, we do not do any care at that point until they can get landed at their East Mississippi or wherever their next unit is to receive services for alcohol and drug at that time. I want to kind of stop there because I can tell you, once we start this, Chairman said we didn't have, I said 2 or 3 hours, we can talk about this all day. It's a passion for me. And I'm not going to sit here and tell you that I know all the answers. By any means, I do not. I'm a person who sees a problem, want to try to fix it, and trying to rally people to that cause and doing the best I can, but it takes a lot of people. Where we're at in our region, and I'm not going to sit here and tell you that every area and every region of this being serviced, because I don't know all those regions and their people and their sheriffs, and it takes a team. It really takes a team, and I'm sure there's other areas that are lacking or better than what we do. But I take a great pride knowing that we do what we do to try to help our mentally health patients and our people who need their help in our area, not just in Lamar County, but for the area. We're trying to upgrade the area systems. So, but
Let me ask a couple of questions. If I walk into your office and I say, I have a son who has mental problems and he's violent and I'm afraid of it, and I've come here to take out papers on it, why am I at the Chancery Clerk's office talking to you instead of somewhere else talking to a mental health professional? And is there a situation where when someone comes in, you ask, why are you here? Why haven't you tried other alternatives? Is that the way things work when they show up?
Well, okay. So the first answer to that is it's by statute how our structure goes through the process. When the person comes in, initiates the process, then it spurs us to XYZ with patient information, then get them to the pre-screener with Pine Belt Mental Health to get another set of eyes, a professionally trained person that can help us ascertain whether this person needs to move forward or not, or back off. And at that point, we try to figure out if it's a volatile situation and you tell us that there's a threatening situation or there's problems, that throws up a red flag. So we tell, as the process goes through, we tell our people that are going out in the field to make contact with the person that this is the potential, okay? And if they are considered to be hostile or violent, then they are kept in the jail. A CSU, they have no, and I don't want to speak for Departmental Health, that's for sure. The way I understand it is there's no security force. There might be a personnel on site, but there's no one there it's usually nurses, nurse practitioner, a doctor coming through, social worker. They can't deal with in another, if it's 16-bed facility and you got 15 calm people and you put someone in there that's liable to throw chairs, beat up someone. I mean, there's only so much, the way I understand it, they can do. So that person at that time is harmful to themselves or others. So we put them in the jail. That's where the judges, and that's one of the things I'll say, the judges play a big role in this. We have a special master that handles our cases, every one of them that comes through. And then the chancery chancellor signs off on them. So it gets 2 sets of eyes on our judicial side, two sets of eyes to make sure that what we're doing is correct. In other words, we don't want to put anyone in services that doesn't need it. We want them to have, if they need it, we want to make sure they get those services. But you are correct. The way to work, the way we do it in our area, okay, we looked at it exactly what you just described. Why do we, like I said, there's a diverse background that may not come in knowing everything about a commitment or a mental health person. How do we get to that comfort level that we feel like we need to put this person into a next level care? Okay. So we then do a pre-screener with our Pine Belt Mental Health does a pre-screener, not a pre-assessment, not a pre-eval, but a pre-screener on that person. or the person doing the commitment paperwork at that time. Gives us an extra set of ears and eyes in the situation to give us feedback. And they may tell us at that time, we recommend diversion. We may recommend doing this or doing that and keeping them out of jail. So we try to divert. And the Departmental Health and the providers in each region, there are, and I'm not sure the exact terminology, but there is a court liaison or a mental health liaison. And we I think had one for a little while, and our numbers went down. We diverted out some, but that's a person who will intensely try to go out and look for diversions to help before we have to take that next level commitment step to commit someone.
Let me try again. Somebody walks into your office and says, I have a problem with my son. I think my son needs to be committed to a mental institution. Is the first thing that happens, someone fills out a form to start a proceeding in the Chancery Court?
Yes.
The first thing that happens is not, I assume there's a deputy that does this. The first thing that happens is not the deputy says, have you called Pine Belt and talked to them? Would you like to talk to Pine Belt before you start filing paperwork here? The first thing that happens is you just process the paperwork.
Correct.
Okay. You mentioned then a diversion. And so right now, is there an attempt, once the paperwork is filled out, to have a diversion? I guess once the paperwork is filled out, there's a proceeding, there's a cause number, there's a petition that's been filed with the court.
Correct.
And so after the petition is filed with the court, then is there the suggestion, would you go talk to Pine Belt?
They do have to go talk to Pine Belt at that point, and they do a assessment with the person that's doing the paperwork. Not generally 99% of the time, they don't have the actual person there in front of them to do the paperwork off of. So they have to take the firsthand knowledge from the person doing the commitment. They do their assessment, get it back to us, and then we proceed on through the process. And once the writ's issued, they're picked up. Then we do have 2 doctors that come in, evaluate within the first 48 hours, and have them, to the point that we are ready to then move forward with our proceedings.
Does anyone ever ask the petitioner who's come in to start the paperwork, have you tried to get help for this individual? Have you asked this individual if they'll go down to the crisis intervention team? Would they go down to a facility operated by Pine Belt and see them?
Okay, so we have an MCERT staff or team in our area dedicated to the region. And so a lot of times whenever people come in and they're having an episode, or we have a lot of CIT trained officers on staff at the sheriff departments, Forest County and Lamar County. And so we essentially, if that person is contacted, that may be their first phone call. They may call MCERT and Pine Belt and say, hey, look, we have a person that you need to have assessed. We do get those mental commitments where MCERT has went out in the field to a issue on site, on location, talked with the person, actually saw them with their own 2 eyes, they'll say and goes, and determined that they needed to move forward with their, healthcare needs. And so they will actually come to the clerk's office and start the paperwork, not a loved one, not a coworker, not someone out there. And so that works well. That is our dream, because then we know a master level technician or clinician has seen this person, evaluated them on site, and comes in here with the paperwork. That helps us tremendously. So does that? Yes, we do have those avenues, but we have the commitment process is one of a lot of duties a chancery clerk has on their plate. And so in my situation where I have some staff, yes, I dedicate a good bit of time to that. We really want to walk these people through this process because we know it's a tough process. And so, but there's going to be some clerks who only have themselves and one other clerk, deputy clerk or something, and they can't dedicate that kind of time to it. So they're taking the word of the people, going by the statute and processing the paperwork. Does that make sense? I hope I answered that for you.
I understood you to say that when the paperwork is filed, a writ is issued to take the individual into custody, and this individual is then, the practice is to take this individual to the crisis stabilization unit. But on occasion, if the individual seems to be too violent, for lack of a different word, that individual is taken to the jail. And that's sort of the screening mechanism of how someone winds up in jail prior to anything other than the officer showing up and taking him to jail.
Correct. I believe that's correct, yes.
I know other members have questions, so I'll stop at that point and see if others have questions. Senator Fillingham.
Thank you, Mr. Chairman, and thank you, Jamie. He's a Sumrall boy, not just from Lamar County, so we're very proud of the work he's doing in this field. About how many percentage-wise, Jamie, would you say once the process gets started and the paperwork is filed, once the evaluations by the two medical professionals take place, how many of them are not committed at that point, but are said, okay, well, you need some help, but you don't need to be in, a full-blown commitment situation? Do you ever see that practice happening?
Yes, our special master has been actually doing the mental health adjudication process for years, and is very good or very well oriented at fishing out the truth of the matter. Because I mean, in all honesty, I could commit anyone. I could go tell anyone that I could go do paperwork on you or anyone.
Sometimes I would need it. Yeah.
But, but he's good at fleshing that out in the process, but as by the time it usually gets to that level, there's enough eyes on it coming through our office, coming through either MCERT or Pine Belt Mental Health with the pre-eval. There's enough eyes come through the process that generally they go through the process and they're recommended for further treatment. Every once in a while, you will get a dismissal. Yes.
But there are like voluntary treatments versus involuntary commitments as well, right?
So there again, it's a different situation for all 82 counties. Okay. We happen to have a jail system who has 24-hour care, on-site care, medical staff. They have access to mental health professionals. We have written SOP standards on how the jails will deal with mental health patients. So they come in and they see just about like statute dictates. They see an RN at first screening, and when they hit the jail, they are honestly starting that care process. And so if they have medications and your loved one brings it to the jail, our medical staff starts that process of getting them back on it. And we have had the issue to where they may stay in the jail for a couple of days or 3 or 4 days, get on their medications, and they're a whole different person. And, but at that point, then the judge has to just decide, do they get handed off to MCERT to continue outside care in a diversion situation, or should we go ahead with a more intense process? And that's where the two doctors' evaluations during their hold and their assessment with the person in front of them moving forward, that they kind of have a lot more information than at that point as to what they think they can do to help that person. That answer that?
It did, because I mean, you see sometimes in Chancery Court, which is what you're involved with, sometimes some spiteful situations where maybe the person really doesn't need to be there, but because of a divorce situation going on or a child custody matter that's being contested, you could have spiteful people, believe it or not, that will fill out paperwork on people to try to make them look bad in a separate court proceeding. And I just wanted to make sure there are ways of teasing that out to make sure if someone truly is being framed and set up and doesn't need that help, they're not just kept there for days on end?
I'll speak for Lamar County, okay? We have a very intensive questioning process going through the patient information, patient history, and we ask those questions to this person, because one of the things that's a trigger, are they violent? Would you say your spouse or loved one, friend, coworker, whatever, are they showing signs of dementia? Is it diagnosed dementia? You know, there's certain things that keep you from being able to go through the process automatically. It takes it out of our hands anyway. And so we start trying to tease those things out, and 9 times out of 10 in a 30-minute to an hour process of pulling that information out, we get that. We start hearing that there's issues, or there was a divorce, or there's something. We go ahead through the process because we let the system take care of that, but we notify the judge and the pre-eval and say, hey, look, this is what we've come to our conclusions. Now, you know, when you do your assessment, tell us what you think. And so it's a multi-step process. It's not just something that you just go taking someone off the street and go put them in jail and do a mental commitment on it. It's a step-by-step process. Now, there's some imperfections to it. There are, but it's what we work within what we can do. So.
And in our regional facility that is housed in Lamar County, would you explain how the funding works? I mean, which other entities other than Lamar County is putting money into that to make that 16-bed facility happen?
So that system, that CSU that we're trying to develop there in the area, it's a partnership where we've brought in Lamar County, Forest County, and City of Hattiesburg have committed funding to it. Actually, the legislative group gave us, I think, $500,000 2 years ago. We had a design team on that for almost a year and a half now with COVID and just all the problems. It's been a very long to get to where we're at, but we're very close to going out to bid. We actually applied for some federal funding and received $2.2 million out of that, $1 million each from the counties, $750,000 from the city. So we've got some substantial funding, over $5 million, to get this facility off the ground, built, renovated, and hopefully projecting to be able to run a year, budgetary wise. But after that, we're wanting to show the state that we want to have skin in the game as a area, a region, and to help with the departmental health and alleviate some of the stress off of their system, because Pearl River County is growing, the Gulf Coast is growing, Lamar County is growing leaps and bounds. Forest County is definitely, you know, their structure set up the way they are with the city and then all in the USM and the facilities they've got with Cary and different things. They're going to hold people. So we've got a problem we've got to deal with in an area, not just one county. And so it's a regional thing. And as we move further along, I'll tell you, we're gonna be asking for help. I mean, we're gonna need it at some degree at some point, and we want to work with our partners at Departmental Health if there's avenues they can help us to be able to supplement too. So
we have always concerns about time, and I know that there are some clerks and supervisors who are here. Or do any of y'all have any comments you want to make at this point? Is there anything you need to tell us?
If there's any clarifications, I would love for Lance, to definitely.
Just to go back to your question about when somebody walks in, probably from the mid-90s.
Excuse me, could you tell us all who you are and
Yes,
all of
sir.
that?
From the mid-90s, probably until a year and a half ago, when that person walked into my door, I sent.
Excuse me, could you introduce yourself?
Yes, sir.
To the committee and the audience, and tell us who you are and what you do and all of that.
I'm Lance Reed. I'm the Forest County Chancery Clerk.
You border on Lamar.
Yes, we're neighboring counties. Yes, sir. And Jamie and I have worked closely with each other since we both took office. But like I said, I've worked in the Chancery Clerk's office since sometime in 1990. But to go back to your question, and the point I was wanting to get to is from sometime in the mid-90s until a year and a half ago, if somebody walked into our office, the first thing we would do is have them contact Pine Belt Mental Health Care and do what's called a pre-evaluation screening. Our theory in Forest County at that time it was better for a mental health professional to talk to that family or that person. And Jamie's right, it's very rare that you get that person to come to your office so that you can actually talk to them. Our theory was we send a family who has personal knowledge of that person's behavior. We send them to Pine Belt Mental Health Care. You get the pre-evaluation screening done first, and then you go from there. Then you do your affidavit. Then you get your writ done. Then you get your appointment of the 2 doctors. And then, you get your writ to the sheriff's office. We take custody. We put them in our evaluation center. A year and a half or so ago, Department of Mental Health Care told me and Jamie that we could not do the pre-evaluation first. So then we started doing what's called a pre-assessment. I really and truly think that Department of Mental Health needs to take another look at, let's do the pre-evaluation screening first. Let's get a mental health care professional to talk to family, somebody who's got personal knowledge, and let's go that direction. I think it would be better for everything. You can divert more people that don't need that treatment. You've got, I don't want to get too far into the weeds, but you have mental commitments where you commit the person directly to the state hospital. There's outpatient treatment. That's a possibility depending on how serious their situation is. There's total dismissal. Those are the options that our special master has when we get to court. But I would love for Department of Mental Health taking another look at that situation.
Thank you. Does anyone else want to mention it? Come right ahead. Tell us who you are. And
I'm Stephen Crotwell. I'm a supervisor from Scott County. I'm also president of the Supervisors Association. And I want to say thank y'all for taking this up. But also, want you to know I'm from a rural county, and I do commend Lamar and Forest County for taking the lead in this. But from a rural county, funding is going to be the issue. It's going to be a major problem for us. It already is. Our jail is full of them. We have no CPS building or nothing like that. The one problem that I'm seeing from an ex-deputy, because I used to go get these people, is that they're the same people over and over. And even when they go through the circuit clerks and get committed, and when they get through their Weems Mental Health or their state hospital, 40, 60, maybe 90 days, we're dealing with them again. So there needs to be something that those people have to act to, maybe give, I don't know. The Weems Mental Health, somebody needs some help for them to follow up, to stay on their medication, so that the Chancery Clerks ain't seeing the same people over and over.
You are in which community mental health?
Scott County and Forest, Mississippi. I was a deputy for 16 years, been a supervisor for 12 years.
Which community mental health center is in your area?
Weems Mental Health, Region 10.
And do they have facilities in your county, or do they have facilities which serve your county? How does that work?
We have facilities that serve our counties, mostly East Mississippi and Meridian. And I think that's the only one that serves us.
There's not a crisis stabilization unit that would.
I would think Weems Mental Health would be what I call the crisis stabilization unit, but yes, we do have a unit, but it serves Newton, Scott, and I think Leake County.
And where is that unit located?
It's in Forest.
And
it's an outpatient deal. It's not you can't keep people there. They don't have a holding facility, but yes, that's where they take the patients to go through their evaluations. Okay. But if that patient is violent or that patient can't get into East Mississippi or Weems and they're violent, they come to Scott County Jail.
Okay.
It's not the place they need to be.
Thank you. And we appreciate y'all coming very much, explaining to us what's going on the ground and what your problems are is very useful. We'll be doing this for 4 years or so, so there'll be other opportunities. But thank you for getting us started today, and thank you for coming. We have the director of the Department of Mental Health, Wendy Bailey, and she has a presentation with her, and also has a handout that has been prepared. And I should say, The handout that you see in black and white is one that I prepared simply with an overview of the commitment process and an attachment having the relevant, at least many of the relevant statutes attached to it, in case anybody wanted to refer to that. And then we'll hear from Director Bailey now, and then we'll wind up with the coordinator of the mental health accessibility, Mr. Roseman. But Ms. Bailey, thank you.
Thank you for having me, and I appreciate the Chancery clerks who are here and who shared what they're experiencing. And I hope I can touch on some of that and address this during the presentation. You also have these slides as part of your handout too. And I'm going to move kind of quickly through this, but first I want to start off, I know most of you know, but what the state's mental health system is. So you have state operated programs and community service programs. Those are like the state hospitals. And then there's 11 regional community mental health centers. You've heard Pine Belt and Weems both mentioned. And then there's other nonprofit, for-profit service organizations. So this is what makes up the state's mental health system. The department has about 650 grants that we provide. It's about $108 million that goes, that we administer to providers throughout the state to provide services. And then we certify about 128 providers that provide these services throughout the state. And then on that first tier with our state hospitals, on any given day, there's about 950 people being served in some type of service at the state hospitals, not necessarily acute psych. And then also at our IDD regional programs and our community homes, there's another 1,200 people, 24 hours a day, 7 days a week, on any given day being served. Okay, so I was asked to kind of do an overview of kind of where we're at now. And so I want to hit on a few targets about progress, challenges, and opportunities within the system. The Olmstead litigation update, I know several have asked about this. This gives you just a really quick timeline. It didn't happen really quickly, but it gives you a really brief timeline here, where 2011, the state received the findings letter from the DOJ investigation. And of course, there was a trial in 2019 in the summer. We had a court monitor, Dr. Hogan, that was appointed, and he produced 4 reports on the state system. And then the state decided to appeal the decision, and the Fifth Circuit ruled in favor of the state and overturned the district court's decision. I get a lot of questions asked about what does that mean and what changes. So we are committed to moving in the direction that we've been moving, and that's community-based services. And that's to wrap services around individuals to where they don't go to the Chancery Clerk's office needing a civil commitment. And I think you'll see some of the progress. Are there still challenges? Absolutely. But we are dedicated to keep moving that system forward and being transparent, producing data, making sure outcomes are being met and people are getting the services that they need. If you want to kind of do a comparison of how we are to other states, this is Mental Health America. They produce a report every year. It's called the State of Mental Health in America. This was the 2023 report. Overall ranking for Mississippi in mental health is 25th in the nation. That was compared to 36th in the nation just a couple of years ago. So we are improving. You can see, though, there are a few areas where it's more challenging now. So, for example, the youth ranking, we were 19th compared to 16th. And you've got these in your slide, but you can just kind of see how we're falling in comparison with other states. Another one that I think is really important to point out is mental health workforce availability. We can't do anything without a workforce. And Mississippi's 42nd compared to 44th in the previous report of having a mental health workforce. So just a couple highlights that I want to mention. Jamie talked about individuals who go into the Chancery Clerk's office for acute psych commitment to the state hospitals. So in FY23, there was 1,965 psychiatric admissions to the 4 state hospitals. We have 320 beds in those 4 state hospitals for acute psych. This was a 9% increase prior to the previous year, but we reopened 50 beds. We were able to reopen 30 beds at East Mississippi State Hospital and 20 beds at Mississippi State Hospital that had been temporarily closed because of staffing challenges and COVID. So when we got our bed capacity back up, we were able to admit more. That also addressed the waiting list. We had a 55% decrease in the waiting list from the previous fiscal year to this last fiscal year by being able to improve that bed capacity. Are people still, though, waiting in jail on civil commitment? Yes. Has that decreased? Yes. In FY22, it was an average of 8 days from the time we got the civil commitment to the time they were placed in a state hospital bed. It is 2.7 days right now is what we're averaging. That's 2.4 was in the last quarter of FY23. But this is a challenge that we are facing in the state. Also, access, again, I mentioned the workforce. Mississippi State Hospital was able to open a psychiatry residency program. We do not have enough psychiatrists in the state. And the first year this program opened was July of 21, and they had about 50 applicants. The last 2 years, they've had over 500 applicants for the residency program, and they're coming from all over the nation, and we are going to do our very best to keep them in Mississippi. We need them to stay. But the residency program also just this past year began operating an outpatient clinic on campus, which is also a wonderful progress. 988, I'm going to talk in just a minute about the crisis continuum. 988 is a 3-digit behavioral health crisis number that you can call 24 hours a day, 7 days a week, and you get a trained counselor. We have 2 call centers in Mississippi. This past fiscal year, there were over 13,000 calls in Mississippi to 988. We have one of the highest in-state answer rates in the nation. In June of last year, we had the #1 highest in-state answer rate in the nation. Our call centers are doing an excellent job, and I'll talk about those more in just a little bit. I'll skip through some of this. Community mental health highlights. So I wanted to just briefly mention a few of these. Earlier, it was brought up people who are coming back for commitment, readmissions. So we know this is an issue. The readmissions at the state hospital, we do have a lower readmission rate than the national average, but still we want to decrease those readmissions more. So one of the things that we've done in the last couple of years to address this is intensive services. Every county in the state has one of these 3 intensive services being provided by their local mental health authority or their community mental health center. PACT, I-Court, or ICSS. These are for people who've had multiple readmissions to the state hospital. PACT and I-Court is a team that works with that individual, wraps those services around them. Again, multiple readmissions. You can see that there were 796 people served by a PACT team. 7% had to be readmitted to a state hospital. People who've had multiple readmissions, so it's working. And then the slide has a few other services that are very important, but I know we're short on time. I definitely want to jump down to the crisis stabilization units because you've heard a lot about that already. So there's 180 crisis stabilization unit beds in the state. You were very gracious and provided us ARPA funding to increase that by 60 beds. There's a new 16-bed unit that's going to be opened up with Region 8 because their CSU is always full. There's a 16-bed that's going to be opened up in Hinds County because they have a high number of commitments and they need some additional beds. The rest of the CSUs that did not have 16 beds, they may have had 8 or 12, are being brought up to 16. So that's your 60 beds. You cannot go over 16 beds for a crisis stabilization unit due to a thing called the IMD exclusion, and it's a federal rule. So we can't have more than 16 beds even if we wanted to. Now, the great thing about these crisis stabilization units, they served 3,400 people last year, and 92% were diverted from state hospital. They did not have to go on to a state hospital. I just got in yesterday, the mid-year data so the fiscal year we're in right now, so July to December, and we've already seen a 16% increase in the CSU admissions and a 33% decrease in denials. This is something that we've been strategically working on over the last 2 years. We shifted funding from the state hospitals to the crisis stabilization units to give them, each one of them, a $400,000 grant that they could use to enhance, to be able to treat more difficult patients. So you mentioned security. Do they need a CIT officer? Do they need a security officer? Do they need more security on their doors? To be able to take some additional higher needs individuals. So we have seen those denials decreased as well. Also, if you look at the first half of FY23 compared to the first half of FY24, we're now seeing a 34% decrease in the people being held in jail. So it is improving. Again, it's a challenge and we've got to continue to work on it, but we are seeing some improvements in this area. So real briefly, I wanted to show you the crisis response, because what you heard earlier from the Chancery clerks is what we want to avoid happening. I'm like Jamie. I wish we could get to a point one day where we don't have any commitments. That's the ultimate goal. I doubt you've probably had somebody stand before you to say, you know, it'd be great if we didn't have to have the highest level of need, but it would be great if we didn't have to have the highest level of need. You have to have a continuum of care. You have to have that, but I want as many people that can be to be served on this end of the continuum. So there's multiple things that you have to have in place, and we have these. We're also working to improve these. We have crisis call centers, that's your 988. We have mobile crisis teams in the state. Jamie mentioned those several times. Crisis stabilization options, those are your CSUs. But then what's so important is that last one that's not often talked about, and that's the post-care, the wraparound care, the continued treatment to make sure the individual doesn't have to go back in a crisis situation. This next slide also I want to show you, because this is a national slide, but it applies to all of our data here too. So you have a person in crisis. This is the person that you asked about earlier that walks in with their family member. You have a person in crisis. First, you want them to know that they can call 988 to talk to that trained counselor. 80% of the time, the crisis can be resolved over the phone by talking to that trained counselor, but that's 20% of the time it can't. So then you have the mobile crisis response teams. We worked really closely with 988 and mobile crisis to develop protocols. So if they get a call and they need to send somebody out, they can dispatch mobile crisis. 70% of the time, that mobile crisis team can resolve the problem in the field. But when it can't be resolved, you have to have those crisis facilities. So that's the CSUs. We actually have a little bit higher of a discharge rate into the community without readmissions. And then again, it goes back to that post-crisis wraparound care. But this does show, 10 years ago, we didn't have 180 beds, we didn't have PACT, we didn't have I-Court, and we had right at about 35% more people being served in the hospital. So it does show you that the services in the community work. I'll skip through a few of these since we focused more on mental health and services in the community. I want to briefly touch on a legislative goal because it goes right hand in hand with what you mentioned. So one of the things that we would love to see is when you look at the civil commitment process, as it was said, you walk into the Chancery clerk's office and you file an affidavit, and then a writ is issued and law enforcement goes and picks you up and takes you to have a pre-evaluation screening. So a writ's been issued and you've had an encounter with law enforcement before a mental health professional has seen you. We would like the pre-evaluation screening moved to the first part of the process. We've modeled this after several different states. One in particular is Minnesota, but there's several states that do this. You see a mental health professional first. Now, we know there's not going to always be smooth and easy. You may have some people that they are actively psychotic, or maybe they are violent, but the mobile crisis response teams can go out. Mobile crisis response is required to have master's level who's trained to do the pre-evaluation screenings. So they can go out and they can do pre-evaluation screenings. And then if there's a situation like that, that may be where law enforcement does have to be called in. or they do go to the Chancery Clerk's office and move forward with filing the affidavit and the writ. But we want an individual to see a mental health professional before a writ is issued. And we just think that that's very key. The other is restricting the use of jails. And there's lots of different ways that states can do this. You can look at having limits on the amount of time. You can look at having limits on you have to be actively violent, or you have to receive treatment while you're waiting, and restrict how long you can wait. So these are just some areas again. But one other thing that was mentioned was, even with the crisis stabilization units, the staffing challenges, and those are still out there. I didn't get into the slide right before that, but you can see the decrease in employees. I mean, there's challenges with staffing, but everybody is making it work as well. So that's another thing that we want to look at trying to address. And then the goals for 24-25, so many of these play into what you've heard today, getting those new CSU beds open, coordinating and making sure more people are aware of 988, the court liaisons. The court liaisons you funded between ARPA, general funds, and some federal dollars. We have 33 court liaisons funded in the state now. 19 are filled positions. The rest are on recruitment. It is a master's level person because, again, they are able to do that pre-evaluation screening. But in FY23, when it was still just a pilot program and we didn't have this many, they had an 88% diversion rate. When the Chancery Clerk called them and connected them with the court liaison, 88% of the time they avoided the writ. So it's a good program, and it's showing that it's working too, and we need to expand it as well. So I know I tried to make that.
Thank you. I'm going to take just a minute to introduce Representative Sam Creekmore, who, as you may know, is the Chair of Public Health in the House. We had, he's the one sitting here, the senator you don't recognize. Chairman Creekmore and I were going to have a joint hearing today. The House convened at 3 o'clock. There's a special session going on, and the economic development project is, in all candor, a really big deal. And so it's the typical thing at the legislative session. Everything happens at the same time. And so we didn't have technically the joint hearing that we'd planned today, but we plan to have those in the future, and Chairman Creekmore and I will work together on that. Representative Creekmore, you've got a microphone, which you're welcome to use, and you've got about 30% of the state Senate right here in this. Do you want to take this opportunity to see if you can do any good with them?
You don't mind.
Sure.
Thank you for kindly letting me come over here. Director Bailey, part of HB 1222, there was a lot of record keeping, and you've sent one email that had all the data that you've received from across the state. Is that helpful? Are there any challenges that have shown up through this?
There's absolutely challenges that have shown up through this, but it's going to be helpful too. So yes and yes. House Bill 1222 required Chancery Clerk reporting, and it laid out the number of affidavits that were filed, the number of hearings, the number of commitments. Then when you contact to try to find a CSU bed, if you get a denial, the reason for the denial. It was very specific information that was being tracked. And the Chancery Clerks haven't had to report it in that detail before. We did that through our bed registry. So we have a bed registry now that has the crisis stabilization beds and the state hospital beds. So you can see which ones are vacant and where those vacancies are. And we wanted to open that up to the Chancery Clerk so they could see, okay, there's not a CSU bed here, but there's one 2 counties over. They could kind of be able to look and be transparent. So we built the reporting system within the bed registry to really encourage them to use the bed registry. And there's been a few challenges with that and consistency with the data, but that happens anytime you've got new data collection. So I'm really hoping by the second quarter, we just sent out the information, and then by the third quarter, by the end of the year, I think we'll have good, solid data. There may be some tweaks that need to be made to it because it's only capturing people who are waiting in jail if there's a CSU denial. But I will tell you, I have had numerous calls from Chancery Clerks since this started, and so many of them have said, well, I didn't know I needed to call my CSU, or So I need to involve my communal health center at this point. And then some said, I don't call the CSU because I hand it off to my communal health center and they're handling it. So it's really been a good educational tool and brought a lot of awareness to it as well, I think.
So any chancery at any time, 365, 24/7, can look and see if there are any beds available in the state of Mississippi.
Yes, we gave them access to that. They signed up with a password and a user ID, and they can log in. And you can click CSU, crisis stabilization units, or state hospital beds. And they can see how many are filled, how many are vacant, and where they are. Also, you've got pending admissions, because you might have some vacancies showing up, but you have pending admissions already. But that is available, yes.
And as far as the data goes, do you, by the end of the first quarter of 2024, do you think you'll have the kinks with the
First-
chanceries worked out, or?
First quarter, maybe 25. 24, that's the one that we just
That's right.
produced, right? So no, that one, I mean, that's one of those things, we had to produce the report because it was required by the legislature, but we know there's so many issues with that data. It's not accurate. I mean, I'll give you an example. There might have been times where it was entered in that there were more CSU denials than there were affidavits filed. So some people, if they got a CSU denial because the person was violent and too medically fragile, they counted it as 2. I mean, it needs some cleaned up and some work. But again, it was the first time for the Chancery clerks, and there were a lot of calls and emails fielded, and we've got more right now that have already input second quarter data than we did before. So it's catching on.
You referred in your presentation to people waiting in jail, and you can be in jail because you've been picked up and you're waiting for a hearing. You can be in jail because you've been committed and for whatever reason, there's not another place for you to go, so you're in jail after commitment. Were your numbers for before commitment or after commitment or all of the above?
So the way that we track it before House Bill 1222, the only way that we tracked it was when we got the commitment order. We, the state hospital, got the commitment order, and then we knew the location of where the person was waiting. So when we say 2.7 days, that's how long the person's had to wait when we got the commitment order. Before the commitment order, the time of the hearing, that's never been tracked before. House Bill 1222 in section 9 tracks waiting in jail if you've had a CSU denial. Section 8 tracks pre and post. We've got to get this part worked out before we can get the other. But the other part will actually track. It's only a one-time data collection, but it will show you pre and post.
But right now, do you have numbers for people who are in jail awaiting a hearing? Is that part of the information that you have at this point?
Right now.
So the information you're giving us right now is only people who've been through the process, have been committed to the state hospital and are waiting for transportation because there's no room in the inn. You also mentioned intensive community support services, a variety of things to help people with difficulties in the various communities. Would it be fair to say these do not exist consistently as you go from county to county?
They don't. Some counties, okay, so there's PAC teams, and that's the most intensive level. I-Court is like a rural PAC team, and there's what's called ICSS, Intensive Community Support Services. So a map was literally laid down to the state, and we looked at where commitments were. The areas that had high number of commitments were PAC teams, because it's also kind of more urban. More rural areas got I-Court teams if they had a certain number of commitments or above. Some counties only have 2 or 3 commitments a year. So you can't really sustain a PAC team with that. So they got ICSS, which is an intensive community support specialist that can have a caseload of 20 and provide that intensive support. It's not a team, it's just one person.
Thank you. Senator Wiggins had a question.
Thank you, Mr. Chairman, and appreciate you having this hearing. I have 2 questions, and I'm going to ask you to comment on it. So admittedly, there's been a rosier picture painted here than I anticipated coming into this hearing, which I guess is good, which means we've had some improvement, but we got a long way to go. And what I've seen, both from talking to my constituents who contact me and also being a practicing lawyer, and I'm going to describe it this way. There's a disconnect between what the psychiatrists think is critical and what family members are dealing with. I can't tell you how many times that during the civil commitment process, whatever it is, the psychiatrists are like, yeah, that's not that bad. And the family is pulling their hair out and they don't know what to do. And this goes back to the clerks. I see them nodding over there. These families come in and they're at their wits' end. And then when the psychiatrist or whomever says, they just need to be back on their meds or whatever, the family members lose it, understandably. Why is there this disconnect? It's almost like in the world of psychiatry, and I don't know if you can answer this, there's a different standard than there is in the community. And right now, the community is suffering.
I'm not a psychiatrist, so I don't want to speak on behalf of psychiatrists. But I will say a state hospital and a civil commitment is that highest level of care. And it's supposed to be for a person who's a danger to themselves or others. I personally went through the civil commitment process with a family member about 15 years ago, 3 different times. It is difficult and it's hard. And when you're in the midst of it with your loved one, it's extremely challenging.
Okay, and sorry to interrupt, but that may be the gap because these family members think and these community thinks that's the remedy. And the psychiatrists are like, that's the worst possible, only in extreme circumstances. And so you're getting these family members and community members who are beside themselves. Am I accurate in saying?
You're very accurate in saying that. I think everybody a lot of times goes, we need a bed. We need a bed. You need community services and you need strong community services that are wrapped around that person to prevent them from needing a bed. Are there times you're going to need a bed? Yes. But the community services, that's why I said it earlier, is so key and they are working. We've got to strengthen them and improve them, but they are working.
But we don't have them like they need to be.
You're right. You've got different counties have different areas. That's also with the crisis stabilization. If you need a bed, we want you to have a crisis stabilization bed first, if you can, because it's a lesser restrictive environment than a state hospital.
Just for a solution, if at a minimum, I think educating, however, community that the civil commitment process for a bed is the worst or the most extreme situation on that. My second question, and this is my last question, is in your legislative goals, you mentioned restrict use of jails as a holding location for someone with a civil commitment, which tells me that throughout the state, there are counties who are holding people on this. In jails, you're depriving people of liberty. Jail, you actually, a crime, being mentally unfit is not a crime. And yet we're putting people in jail. And you're requesting legislation. So can you comment on what's going on and why you're bringing that and why these counties, and I'm going to say this, Jackson County, where my county is spending $3 million to $4 million of its own budgetary money to build a 16-bed CSU because it's gotten to the point where they need to do that. If Jackson County, understandably, that we got more population and all that, that's so that they aren't held in jail. So can you comment on that?
Yes. Okay. So the reason, yes, we're asking for that legislation because it's happening. I mean, it's happening across the state. In your first question also kind of ties into something I want to say in the second one. And I think one of the key solutions here will be the court liaisons, because when the individual comes in to the chancery clerk and they don't have any other option, they think, if you can connect them to the community mental health center and connect them with the court liaison to try to divert them then, instead of we're doing the diversion after the writ's been issued now, and we need to do the diversion on the front end. So I think that's a key. That's also a key, I think will be a key in helping people not be automatically placed in jail, not picked up on the writ and placed in jail. We can divert the front end. But now the jail holds, absolutely, it's a problem. And the crisis stabilization beds are a key to that. And with the ARPA funding too, we've been able to help with the Jackson County one. You've got to have the beds, you got to have the community services, but then you've got to have the people to help on the front end for the diversion and the connection of those. I don't know if I answered.
No, you did. And just to finish it, I'm not picking on anyone.
Yeah.
But that's not the law that somebody is to be in jail because they've got a mental illness and yet it's going on. Do these counties not understand that's what the law is? And arguably could be opening the state up to litigation even further. I mean, you're depriving people of their liberty.
You're exactly right. There's due process, and you're exactly right. And you've got you've got some counties that are doing it much more often than others. Others you can see it might be where there was a very serious or a violent situation. So there's certain areas that you can see where it really needs to be focused on. But having a mental illness is not a crime. And if you are sick and you need a court commitment, that is not a reason to place an individual in jail unless they have charges. If that person doesn't have charges and they're being placed in jail only because they're in need of treatment, we do not need that occurring in our state.
We have time for one more question if anyone, Senator McMahon.
Mr. Chairman, thank you. I'd like to go back to Clerk Reed that testified earlier. If you'd take the microphone, Mr. Reed, or Clerk Reed. So you said you represented Forest County and you've worked in that office for over 25 years?
Yes, sir. Probably more like 33.
33 years. So let's just talk about maybe the 2023 year. How many commitments have y'all had that year in 2023?
2023.
Just roughly. I
Yeah,
mean,
170-ish.
170?
Yes, sir.
And of that, how many were dismissed, would you say? Or do you think they were falsely charged? Would you say?
10 to 12.
Okay, of those 10 to 12, did the prosecutors go after them for filing fraudulent paperwork against another individual?
No, sir.
Did your office recommend they go after? Because I do think that there are some families that are weaponizing our legal system against others, and I think mental health is one of those areas that's being weaponized against.
One of the scariest things is divorce. So,
Yes, sir.
And that to me is what you're looking at is one of the questions that we ask is, are you going through a divorce at this point? And if you are, that's the red flag pops up. And then at that point, usually we do not proceed any further until there's more investigation. The ones that do get dismissed that I've dealt with over the years, there's only been a handful. They were all in divorce situations where husband one time was getting all the farm equipment and heading down 42, leaving with it. And our deputy actually figured out what was happening, one of our deputy sheriffs. And of course, we got that stopped. But here recently, I don't, we haven't had an issue where we pursue that person.
So of the 160, or excuse me, of the 158 cases that you dealt with, you would say last year, how many of those do you think were drug related?
If 45-ish, somewhere in there.
Maybe about a third?
Yes, sir.
Okay. All right. Thank you.
Yes,
That's
sir.
helpful. Thank you.
Thank you, and thank you for coming with a very helpful presentation. Oh, well, Senator Hill.
Did y'all get it worked out to where if there is a bed in another catchment region, that person can be transferred into that catchment region where there is an open CSU bed?
Yes, they can. That was one of the reasons to have the bed registry transparent. Absolutely.
Okay, I just wanted to make sure because we had talked about that
Yes.
before.
Thank you. And thank you for coming to testify. Mr. Rosamond, as you know, legislation several years back set up the Office of Coordinator of Mental Health Accessibility with the notion that we needed someone out in the counties going to see what's actually going on the ground. And if there's a problem, having both the legal authority and one hopes the persuasive authority to try to solve some of those problems. As a result of that, I think that some of the community mental health centers have merged, and I do think we've got better services statewide than we had previously. But Mr. Rosamond, I'll let you pick it up and go from here.
Chairman, thank you, members of the committee, for the opportunity to appear. In the interest of time, one thing that I want to.
You have to speak directly into the microphone. You know, this is a state-of-the-art sound system. It's the best that money can buy.
Is that better? In the interest of time, the first thing I want to address is the issue of persons waiting in jail. Mr. Chairman hit on a important point, I believe, earlier. Are these people waiting in jail after they've been civilly committed and waiting on a state hospital bed, or are they waiting on a commitment hearing? Where is this happening? Is it happening more in rural areas where there are less resources? I believe that it is, possibly, and I wanted to talk to you about potential solution as to how to address that problem. The crisis stabilization units are very helpful, but statute provides for a holding facility. And looking at that, that is clearly different than a crisis stabilization unit. According to statute, that is a place for 24/7 mental health, medical care for someone awaiting commitment proceeding or commitment. And we have a pilot project we have been looking at involving two regions, Region 8 and Region 10. Region 8 in the Rankin County area and Region 10, Weems and Meridian. And a potential solution there would be for the crisis stabilization unit to be dually certified as a holding facility for people that are involved in the commitment process. The Department of Mental Health produces data on crisis stabilization unit denials. One reason for denial is a person is too violent. So that means they can't be held in a crisis stabilization unit according to crisis stabilization unit personnel. The ask here would be that the CMHCs admit persons, well, first that they be duly certified, the CSU be duly certified as a CSU and a holding facility, which is allowed by statute now, that they admit persons to the holding facility, CSU 24/7, which there should be their practice now. I'm not sure that that always occurs. And that they have a safe room or safe area in order to have a place to keep persons as an alternative to jail, that they be able to administer a therapeutic or calming agent, which they are also allowed to do currently by Department of Mental Health regulation. And in addition, that they have MOUs with law enforcement and state hospitals as to how to handle certain situations. It's been mentioned throughout, there are a lot of good people out there that are interested in helping this process, but we need a defined process to make sure that people aren't waiting in jail at all. Sheriffs would need, law enforcement would need to be able to transport people 24/7. They would need to be willing to wait around a few hours, an hour or two, until the person is stabilized, safe to stay at the facility without a law enforcement presence. We've talked to at least one Region 10. They do not currently employ security at their CSU. But what they do look for is persons with a law enforcement background that are trained to realize situations when more violent people are there. And additionally, law enforcement would need to be willing to transport a person to the state hospital if the person could not be handled at the holding facility. For the state hospitals, there would need to be a minimal number of beds designated to handle persons potentially that have not been committed yet, that could not be handled at the holding facility CSU. And they would also need to admit this limited category of people 24/7. We have had extensive conversations with, again, Region 8 and Region 10. They are willing to participate in this pilot. This pilot would not change any other initiative or anything that's currently going on with the system. It would not add people to the system. Additionally, the community mental health centers, the CSU, would serve as a single point of entry. And that would help people, as Director Bailey said earlier, that, a determination, crisis analysis, a pre-screening would be done at the CSU to determine if the person is appropriate for commitment at all. Perhaps a person is nonviolent, but they're waiting in jail because the county that they're in, unfortunately, doesn't have the resources to house them elsewhere. Those persons do exist out there. So that is a proposal that we've gotten a lot of positive feedback on. Additionally, I'd like to update you on the things that we've been working on over the past year. Region 11 Community Mental Health Center in Southwest Mississippi was dissolved on June 30th, and Regions 12 Pine Belt and Region 15, which was Warren Yazoo, now River Region, is providing services to the counties in Southwest Mississippi. We, in early 2022, according to statute, declared that services in the region were not sustainable and delivery of services was inconsistent. In that effort, we began consulting contiguous regions and other regions as to see if there are CMHCs that were interested in providing services in those areas. We were not able to find any takers for a period of time. In July of 2022, we began providing operational and technical assistance in the region. We established programs along with the region, such as psychosocial rehabilitation services, memorandums with schools for day treatment for children and youth, and saw an improvement in services there, but nonetheless, the region still needed to be shut down. And fortunately, we were able to find partners with 12 and 15 to accomplish that. We, through this process, found a lot of people that were very aware of what was going on in Southwest Mississippi, very willing to help with this process and ensure that services are in place. So we appreciate the legislature and also county officials in that effort. When the determination was made that the region needed to be shut down, the Region 11 was in $850,000 of debt. It cost over $1 million to shut the region down. That money was found between selling Region 11 assets through a $300,000 contribution from the 9 Southwest Mississippi counties that were formerly served by Region 11, and a matching contribution from DMH, from grant funds that were allocated to Region 11 and other CMHC regions. And it was determined that services were provided in other areas that were not eligible to receive the grant funds. And DMH, I appreciate, was willing to compensate for those services. So this dissolution was accomplished without any request for new state funds to do so. And I believe that better services are clearly in place today. Additionally, there was another dissolution of Region 1, that is the Northern Delta region, and Region 6 Community Health Center. They began providing services in that region on February 1st of this year as well. I'd like to provide you a general financial update on the community mental health centers right now. I think the liquidity of the system is more than adequate right now. For the 12-month rolling period, 8 of the 11 CMHC regions had net increases in their financial position. There are 2 regions currently that are having financial issues. Those are Region 9, which is Hinds County, and Region 14, which are Jackson and George counties. We are working with those regions now, providing operational and technical assistance. We've seen some improvement in their cash balances through the third quarter from the first quarter, and we don't see either of those situations approaching anything like Region 11 or any need for any dissolution there, but we continue to work with those regions. We have also undertaken efforts to help the behavioral health workforce. In addition to psychiatrists, there's a shortage of counseling-related personnel in community mental health centers. According to a snapshot that we did on a given day, there are 250 counseling vacancies in the community mental health centers. So what we were able to do there, and working with a public university and the Department of Mental Health and the Division of Medicaid, was our ask was that the Department of Mental Health create an avenue through their provisionally licensed mental health therapist to provisionally license people that they've completed their academic coursework, but they have not completed their internship. That's about a 4 to 6 months process. If you got somebody that's working to pay their way through school and they have to quit their job in order to enter a counseling related profession, that would certainly be a deterrent from doing so. The department was willing to offer a waiver for persons who had completed their academic coursework. So the anticipated outcomes of this are a reduction in the behavioral workforce shortage, increased revenue for the community mental health centers, and hopefully additional persons interested in entering the counseling profession. We have undertaken efforts to educate the community about the community mental health center regions through our quarterly status reports. We've made written recommendations, such as encouraging all CMHC regions to promote and pursue the development of CIT in their regions, to publish official minutes from their commissioners meeting. And we've also made requests to the Department of Mental Health to make the bed registry for the state hospitals available to the Chancery clerks. And Wendy had described that earlier, and appreciate that as well.
Thank you. Just briefly to remind members of the committee of some of the things you mentioned. There has been for years a difficulty with the community mental health center in Southwest Mississippi, about 10 or 12 counties, going from Natchez to Macomb. The services were just not being provided. There were financial problems. And over a course of several years, by meeting with the boards of supervisors in each county, talking through the problems, looking at the facilities where in theory things were taking place, but in fact were not. At the end of the day, a solution was found to have two other community mental health centers absorb those counties. The counties, I think, voted to be absorbed. And that's been accomplished. Services are much better. The people who live in those counties are getting better services. And I think it was accomplished without, an uprising from the local community that somebody's coming in and taking over. I think out in the real world, we got about as good a solution as anybody could hope for. But that involves a lot of moving parts. It involved the Department of Mental Health, funds from the Department of Mental Health, all of those counties, funds from all of those counties, two other community mental health districts. It's one of a number of problems we find that involves just a whole bunch of people. We have the ongoing problem that we've been discussing today from a number of presentations about what to do about people who are violent. Again, that's probably the wrong word to use, but people who are thought to be violent, who are in need of mental health. What do you do? Where can you put these individuals other than jail so that they can actually get some treatment? The existence of crisis stabilization units is a major accomplishment in better healthcare everywhere. But that is one possibility of places to take care of some of this population. But again, it takes working with the sheriff's office, working with the crisis stabilization unit, working with the Department of Mental Health, working with a bunch of other people. We have a shortage. Number three, you mentioned a shortage of counselors and available at just generally everywhere. Everybody has a problem with staffing at every level. There is a proposal to have a situation in Meridian where those who are receiving training toward the end of their period, can get some revenue so that they can afford to get the additional training and provide additional services then, and be a pool of additional people for workforce all over the state. That involves a university. It involves the facility there in Meridian. It involves Medicaid. We have problems that involve many different agencies. And so the purpose of the having the coordinator is certainly not to usurp anyone else's authority, but simply to be a place where there's some entity that doesn't have to worry with the day-to-day existence of being a sheriff's department or running a facility or running a department. They can step outside that and have some time to think critically and have the duty and the ability to deal with 18 different people and keep working on one thing. And so that's where we are now. Having said all that, questions for Mr. Roseman? You want? Okay. Thank you. We appreciate the presentation.
Thank you, sir.
I don't want to say that I can speak generally for Representative Creekmore, but I think I can speak for him and me in the comments I'm about to make. We want to improve mental health care in the state of Mississippi. We don't care about finding villains. We don't care about allocating blame. We're not trying to do any of those things. We're not trying to make anybody look bad. We'd like to make everybody look good. What we're trying to do is actually find out what's going on. What are the problems and what can we do to help? We in the legislature can pass legislation, but we can also jawbone. We can also talk to people. Generally speaking, folks will return our phone calls, So all of us are pulling in the same direction. The individuals who work in all of these facilities around the state, the Department of Mental Health, the various community mental health centers, the people who filed the lawsuit in federal court, the goal that we all have is, it's a common goal of just how do we improve mental health care? And I think it's obvious from the data that the Department of Mental Health showed that we're moving in the right direction. We're making progress. Everybody on every level is moving in the right level and making progress. And that's because of a lot of hard work on the part of a lot of people. But we all need to continue to work together and continue to make improvement. And that's the goal. And I think it's a focus that Chairman Creekmore and I have for the time that we're both chairs of mental health. Is that okay? Is there a motion to rise and report? All in favor say aye. Opposed, no. Aye. Thank you. Thank you. Thank you.